Hello, this is Jake MD, and today I'm going to talk about narcotic pain medicines for post-surgical pain management. I'll talk about ibuprofen and Tylenol and other forms of pain management in another lecture, but today we'll focus on the opioids because that's what most people have heard about, what most people are concerned about as far as post-surgical pain management. Um, So things we're going to talk about today and discuss is post-surgical pain management. We're just going to talk about the most common medicines, and we're going to use common clinical things that I see in my personal experience, not so much textbook definitions of things. I'll touch on those things a little bit, but the onset times and durations of medications might not be exactly what you see in textbook just because I'm going from memory and not from any published material. And I also want to emphasize that narcotics are not the only way to manage pain, and they're an important aspect of pain management, but they're not the end all be all. So we'll discuss other things at another time. For starting out, I wanted to go by IV pain medicines, and then we'll move on to the oral pain medicines after that. And the one that we probably use most often in the operating room while the procedure is going on is IV fentanyl. And this is a synthetic opioid. It is favored because it is a fast onset medication. It is starts working in less than a minute or approximately a minute. Its peak effect is about 5 minutes, so you can see the full effect of what you're doing very quickly, which is nice in the operating room. It also doesn't last a long time, only about 20 minutes or so, 20-30 minutes. And what's nice about that is that if something changes in the operation, if a painful part of it is done, or a nociceptive stimuli portion of it is done, then that pain medicine will go away and you won't have to deal with low blood pressure and not breathing from the high opiate levels in your blood system. So that is why anesthesia providers like these when we're in the operating room and the patient's under general anesthesia or even under a MAC or where you're just getting some conscious sedation or moderate sedation. Fentanyl is a drug of choice for that purpose, and that's the reason why. Next pain medicine I like to talk about is IV hydromorphone, also called Dilaudid is its brand name or trade name. This medication we use for longer acting pain management, so usually near the end of a procedure to make sure that when you emerge from general anesthesia, you are more comfortable and have some time to settle in before you need to start taking your oral pain medications, or the PACU nurse that you're waking up with would need to give you a lot of more IV pain medicine. It's kind of to tide you over to make sure that you're comfortable in that mean handover time between the operating room and the PACU area. Onset time is about 8 to 10 minutes, so it takes a little bit longer. You have to think ahead a touch more than with the fentanyl, but and its peak effect is also longer, 20 to 30 minutes. So it's something that if I give right before you're waking up, by the time you get to the PACU and are starting to remember what's going on, you should have a good effect at that time. So that's what I kind of use it for. And the duration of IV Dilaudid is usually around, I think of it as like 2 hours. It can last up to 3 to 4, but for acute surgical pain where you really need the um, bulk of the effect, I think of it more as a 2 hour drug to just over 2.5 to 3. IV morphine. Now, this is a drug that in adult medicine, at least in anesthesiology, is barely ever used. In pediatric anesthesia, though, this is used all the time. And the rationale for why IV morphine is used in kids and not in adults is basically a dosing one. And it's because morphine needs bigger doses in milligrams in order to give adequate pain relief for an adult than the hydromorphone does. So it's the long-acting drug of choice for kids because they are a lot smaller, so therefore the doses they need are a lot smaller, and then the milligrams are much easier to work with, since a standard little bolus dose of hydromorphone is like 2.2 milligrams, so you're already under a milligram, where a standard dose or an equivalent dose would be about 6 milligrams, probably like zero point 0.4 of hydromorphone, 0.4 milligrams of hydromorphone would be about 6 milligrams of morphine, approximately 5 or 6 milligrams of morphine. So let's shrink down from an adult to a 6-year-old. Half a milligram or 1 milligram of morphine might be perfect, and it's a lot easier to work with that than to work with like 0.05 milligrams of Dilaudid. You can see where that would be very difficult to draw up and very difficult to work with. So that's mostly a convenience for dosing thing as to why morphine is used a lot in children and not really used in adults. So just briefly about it, onset time is about 5 minutes. Peak effect is 20 to 30 minutes, and it lasts about 4 hours. So it has a little bit longer duration than the IV hydromorphone, but it's a little bit less convenient to use, so we tend to use the hydromorphone. Also, morphine can cause a little bit more respiratory depression, all things being equal, so a little bit possibly less risk of having sedation and troubles with really low respiratory rates with the hydromorphone. Specialty IV meds. So there's several other IV narcotics that are used for very specific reasons in the operating room. Remifentanil is the only one I'm going to discuss, just because it's the one that's probably used most frequently, but not one that you'll ever really see in someone who's awake. So under general anesthesia, remifentanil is a drug of choice for doing like spine surgery, brain surgery, anything where they're doing neuromonitoring or where they don't want paralysis, but they also don't want the patient moving at all during the procedure because they're doing something very delicate or something that could be harmful if the patient did move for any reason. And remifentanil causes this immobilization without actually affecting your muscles at all. And the way it does it is that you can use very high doses of remifentanil without worry that the patient isn't going to want to breathe at the end or wake up, because its duration of action is so short. And you can see the peak effect is about a minute, but it only lasts 8 to 10 minutes. So you can be under complete pain relief to the point where you can have somebody talking, or somebody who's able to open their eyes, squeeze your hand when you ask them, but they won't breathe on their own because they're so comfortable that they don't even feel like they have to breathe, which is a very good medication for under general anesthesia, but it is not a safe medication at all, especially in the doses we use in the operating room for someone who's awake or somebody who is not under the care of an anesthesiologist at that particular time. So this is not a medicine that you'd ever get after a surgery or anything like that. It's just too dangerous of a medication, and the dosing of it, you basically need to do a continuous infusion. It's not something that you can just give a single dose of and have it be effective. It's something that you have to have continuously going, otherwise it just doesn't last long enough to be useful. So that's all we'll say about that one. Moving on to the oral pain medicines, so you'll see the difference between intraoperative, we use the IV stuff. Immediately post-operative, we tend to use IV stuff. And then if there's a reason that you can't eat anything, let's say you had a bowel surgery and they don't want you eating anything, if you are nauseous, we don't want to give you a pill that's going to make you more nauseous, so we'll stick to IV pain medicines. If there's a risk that you'd have to go back to the operating room for any reason, let's say if you have a free flap done with plastic surgeons or something else that has a high risk of needing to go back to the operating room, then we'd also tend to stick to the IV medicines and avoid these oral ones. And to bridge that gap, usually when you're awake, we do PCA, which I have another lecture about if you want to hear more about that. That goes into a lot more details about benefits and risks of PCAs, and a PCA stands for patient-controlled analgesia. I won't go talk any more about that since there's a separate talk about that if you don't like to hear about it. So the first one, and the one that you most commonly hear about and most commonly know about, is called oxycodone, and that is very good medication. It's the workhorse of the oral narcotics, I'd have to say. I'd say the standard dose is 5 milligrams, although if you're on it for a while or having extensive surgery, it definitely can be more than that. Usually they're in increments of 5. If someone's very sensitive, you can change in increments of 2.5 milligrams also. Onset times like 30 minutes. 45 is probably a little long, but that's what I put down. And then duration is 3 to 4 hours. If you're having severe pain and you are having good control right after the doses, but it's kind of petering off, I'd say that every 3 hours is probably the right duration of dosing, and 4 might be a little bit too long, because it just starts to taper off before 4 hours is completely done. And at least at the institutions I've worked at, anesthesia teams tend to dose oxycodone every 3 hours, and that is done. You still have to ask for it. It's PRN, or per request, and not something that we schedule as you're going to get this every 3 hours no matter what. And we do that for safety, because if you can stretch it out a little bit, you don't need that pain medicine. We don't want to make you overtired either. So that's how we dose all of these narcotic pain medicines, is by your request. And then I find that in the ICUs and the floors, when non-anesthesiologists are ordering these pain medicines, usually they order every 4 hours, and that's just for a little bit higher margin of safety with people who are usually not quite as comfortable with these pain medicines as anesthesiologists are, or the pain needs are not as significant, because usually the people who have the hardest to control pain get managed by a special acute pain service team, and or if you have a nerve block or epidural or other special infusion for pain management, you might also be followed by the acute pain management team. But otherwise, the surgery team or the ICU team or medicine team, whoever is following you, would be managing those meds, and that tends to be a Q4-hour dosing for those services for whatever reason. The next medicine that I like to talk about is the oral form of Dilaudid or hydromorphone. So it's a pill form. We normally give in increments of 2 milligrams. So a 2 milligram hydromorphone dose is equivalent to about 5 milligrams of oxycodone. So it's a little bit more potent pain medication, but it works roughly the same way as oxycodone does. Onset time is a little bit quicker, probably about 20 minutes, and the duration is also 3 to 4 hours. I'd say that you might get a little bit longer out of the PO Dilaudid compared to the oxycodone, but it is really a personal experience type thing, not necessarily a hard and fast rule. I also wanted to talk about oral morphine with the same caveat as I did with the IV morphine. Although this tends to be given a little bit more frequently in adults than the IV version of morphine. And onset time is about 30 minutes. I'd say that's pretty fair, and duration is 3 to 4 hours. It can cause a little bit more itching than the other medications, but otherwise the side effect profile is very similar, and we'll talk about side effects in a little bit. There's also an extended release morphine, which can last for up to 12 hours, and that's where you see it mostly used in adults, because people like to use that longer lasting pain medicine. And for acute pain, I personally don't like the longer acting stuff because usually you need the pain medicine for shorter periods of time, like if you're going to be active, and if you take a bigger dose than you actually need um, and it lasts a long time, you have to live with those side effects for the full 12 hours. Or if you're going to be going to sleep or doing something where you don't really need that much pain medicine, you end up taking more and having a higher burden of narcotic than you actually need, and that can be harder for you to taper off of that narcotic. And when you do use that bigger dose when you're having more pain, it's not going to be as effective because you build up more tolerance. So those reasons, and it's harder to taper if you're used to having it on all the time. So for those reasons, I like to avoid the longer acting pain medicines for acute pain management. The dosing is a little bit less convenient if you're doing it every 3 to 4 hours compared to every 12, but you shouldn't be working, driving, operating heavy machinery when you're on those narcotic pain medicines anyway. So you should have plenty of time to work on your pain medicine dosing and then to make sure that you're just taking it when you feel like you need it, and that can make it so you can stay comfortable but also try to wean off of those pain medicines as quickly as you can. Since a lot of people are worried about addiction and side effects of these pain medications, which we'll talk about in a bit. Hydrocodone, I kind of threw this one in here. This is a weaker opiate than the rest of them, and the reason why I threw it in here is because it is bundled with a Tylenol or acetaminophen, and therefore you have to really be careful about the dose that you take, because you can actually, if you're taking this with Tylenol, you can overdose on Tylenol, and that actually can cause liver failure, and you can be in the ICU, and it can be really, really terrible. And for this reason, a lot of children's hospitals and stuff don't actually allow hydrocodone, or Percocet is another mixed med, Tylenol plus oxycodone together, because those mixed meds put you at higher risk of having Tylenol overdoses that you don't realize. Because a lot of your over-the-counter cough medicines and cold medicines also have Tylenol bundled in, and you can end up taking a lot more Tylenol than you think that you are. And if you're going to be taking Tylenol on a normal daily basis, the absolute max dose per day is 4 grams. If you have any trouble with your liver, kidneys, or aren't in perfect health, I'd recommend 3,500 milligrams or 3 grams, more in that ballpark, just for a margin of safety, because a Tylenol overdose um, does kill people, does cause people to need liver transplants, and is not a benign thing. Just because Tylenol is over the counter doesn't mean it's safe. And I'll talk about that more in a non-opiate lecture, but I just think that that's really important, so I'm going to emphasize it here as well. And now we'll get to the things that people worry about, which is the side effects of these medications. And I want to really distinguish the difference between a side effect and an allergy. And maybe we'll even dedicate a separate lecture for this topic, because a side effect is what I have here. Itching, nausea, vomiting, feeling tired or disoriented, just not feeling yourself, having that mental clouding, unable to do like complex thinking or logic, which is why we don't like people to drive or operate machinery or do those types of things. And then really the main one that I care about as a physician is respiratory depression, and that's where you breathe slower. And all opiate medications cause, or narcotic pain medications, opiate is just from the opium poppy, so that is a naturally occurring opiate, which is a narcotic pain medicine, and then opioid is a derivative, and then they're usually synthetic. Small point, not very important here. But the main things to know is that all narcotic pain medicines can cause any or all of these side effects, and taking lower doses makes it so you are less likely to experience these side effects. Some of them you will build tolerance to, which means that you will be less likely to experience these side effects if you take the medication longer, and some you do not build tolerance to. So things that I do not have listed here, but you do not build tolerance to, is the pupillary constriction from the narcotic pain medicines. So you'll see people who are on high dose pain medicines will have very small pupils. You do not get um, any protection from the constipation. Your guts will slow down, and that's why most surgeons will put you on a laxative or a stool softener to try to limit that side effect, since it's almost universal. And once in a while, switching classes of these medicines will be beneficial for decreasing side effects, but most of the time it's just that you've been on them long enough that you build that tolerance to like the nausea and vomiting and those types of side effects, that it's not necessarily the switching of the pain medicine that's making a difference, but it's the duration of total that you've been on the narcotic that's making the difference. But if you're having a lot of trouble or side effects with these medications, it's definitely worth talking to your doctor and seeing if you can get a switch to something that you might tolerate or like better. So now I'd like to briefly discuss allergies, and I want to make a big point that allergies and side effects are very different. Allergy includes rash, hives, swelling, especially in your throat, lips, tongue, trouble breathing. You can have a fast heart rate and low blood pressure. And allergies are medical emergencies, and you should seek medical attention right away. Side effects are generally not medical emergencies and do not have to seek medical attention. And these are different in my mind, and I want them to be different in yours because it makes a big difference for how I care for someone if they have a true allergy, which with narcotics is pretty rare but possible, and a side effect to a medicine where I can use a different one in that class that will likely or may work better for you or in your particular situation. Where an allergy, I probably wouldn't want to use anything even close to that class because I'm worried that they could have cross reactivity, since many of these medications bind to the same receptors and work in very similar ways. I think that covers opiates pretty well. If you like this video, please leave a comment or subscribe and give me a suggestion for a future topic. Thanks.